Hello, and I'd like to welcome all the attendees attending today. Thank you for joining us for the AGA webinar on the impact of changing federal policies on physician reimbursement. I'm Peter Margolis, the chair-elect of the AGA Regulatory Work Group, and I'm a member of the AGA Institute's Practice Management and Economics Committee. I'm a private practitioner in gastroenterology in the state of Rhode Island. Today we are joined by Ms. Rachel Groman, who is Vice President of Clinical Affairs and Quality Improvement for Hart Health Strategies, which is a consulting firm in Washington, D.C. that the AGA has been working very closely with. During this webinar, we will go over the federal quality improvement mandates that are currently affecting your practice and affecting how you're reporting on your patients. Ms. Groman will begin the presentation by reviewing these programs, including the Physician Quality Reporting System, the Value-Based Payment Modifier, the Electronic Health Record Incentive Program, or better known as Meaningful Use. We'll discuss how it impacts your practice and how it's impacting your patients and how you guys can participate. I was asked to then discuss my practice's experience with a successful program or process implementing these programs. I'm hoping to provide a guide for those of you who are struggling with the process and those of you who may be just starting the process. Please note that we'll be answering questions at the end of the presentation, but that you can submit any question anytime by using the question pane, which is down on the right side of your screen. This webinar is being recorded, and it will be posted on the AGA website for future use. At this time, I'd like to turn the presentation over to Ms. Groman. Rachel, if you could please begin.
Sure, thank you, and good afternoon, everyone. So I titled the portion of the webinar, my portion of the webinar, Federal Quality Improvement Mandates, the Gathering Storm, because as I suspect many people on the phone know, physicians are currently in the center of the paths of multiple colliding fronts in the form of federal requirements related to quality and value. While these programs all started off as few in number and voluntary in nature, they're now pretty numerous. They often have complex, overlapping, and even conflicting requirements. They're also now, in a sense, mandatory, since failure to participate and satisfy program requirements will result in reduced payments to physicians. These quality reporting cuts come on top of scheduled Medicare payment formula cuts, known as the SGR, as well as automatic deficit reduction cuts that are set to slash physician rates even more. Fortunately, the AGA does continue to work hard to minimize these regulatory burdens through educational forums such as this one today, and data collection tools to help you easily satisfy reporting requirements and avoid penalties, which I'm going to talk about in my presentation. Next slide, please. So this table of Medicare quality payment adjustments illustrates the various quality-related payment adjustments that physicians will be subject to over the next few years. I just want to note that the percentages listed here represent adjustments to the total annual Medicare Part B allowed charges, whether they're penalties or incentive payments. While physicians can continue to qualify for bonus payments in the early years, all of these programs, as you'll see, transition to penalties by 2015. As you can also see, physicians who are unable to report quality measures to CMS through the Physician Quality Reporting System, this top line here, the PQRS, in 2013 will face a penalty in 2015. Practices that are unable to adopt and use EHRs in 2013 and 2014 will face another separate penalty in 2015. And starting in 2015, physicians could receive yet another pay cut from the Medicare Value-Based Payment Modifier, the last row, which adjusts physician payments based on quality and cost performance. And I included two other lines here, the PQRS, MOC, and the e-prescribing programs, but we're not going to get into those today only because they are essentially ended last year. The reporting periods are over, but I just wanted to illustrate the many programs facing physicians right now. Next slide, please. And actually, before I actually move to the PQRS, but we could stay on this slide, I want to also note something I mentioned earlier, that all of the incentive payment amounts you see there will actually be reduced by another 2% due to the sequestration process, which requires across-the-board reduction in payments across all of federal programs. So if let's say your PQRS incentive payment came out to be $500 in 2013, you'll actually only receive a check for $490 due to sequestration. So next slide, please. The first program I'm going to talk about, which you are probably all most familiar with, is the Physician Quality Reporting System. This program gives physicians up or down payment adjustments based on the reporting of quality measure data for Medicare Part B patients to CMS. There are multiple reporting options available to physicians. You can report quality measures as an individual or at the group practice level. You can report on individual measures or measure groups, which are groups of clinically relevant measures that must be reported all together as one. You can report through claims, through a qualified registry, what the CMS qualifies as a registry, through an electronic health record, or through a new reporting option for 2014, which is known as the Qualified Clinical Data Registry option. And we're still learning more about this option, but these are essentially registries that report on non-traditional PQRS measures, measures that the registry may be collecting and may have developed on their own and have not traditionally been used for federal reporting requirements. The PQRS does include different reporting requirements for avoiding the penalty and for earning the incentive. The avoiding the penalty is sort of the bare minimum reporting requirement, but there are separate, more robust requirements for qualifying for an incentive. Fortunately, there is still time to take action for 2013, even though the calendar year has ended, and that will allow you to earn a 0.5% incentive in 2013 and avoid a 1.5% penalty in 2015. Next slide, please. The way to do this for 2013, even though I said the year has ended, is fortunately the AGA provides the Digestive Health Recognition Program, which is a great option for reporting because you report one set of data which allows you to earn the incentive and avoid penalties under PQRS, but also to do the same under private payer recognition programs. It allows you to gain public recognition for excellence and quality through Bridges to Excellence, and you can also receive ABIM MOC credits through this. Through the Digestive Health Recognition Program, you will report a set of measures, and AGA will submit that measure data to CMS for you. So it's a pretty easy way of submitting data. And to still qualify for 2013, what you would have to do is report one of the measure groups available through the DHRP, which I'll go over these in a minute, but either there is a set for IBD or for hepatitis C. And you would have to report on 20 or more unique patients, a majority of whom must be Medicare Part B patients. But 20 is the minimum, and you don't have to report more than 20. 20 is sufficient. To do this, you have to get the data to the Digestive Health Recognition Program before the March 13th, 2014 submission deadline, again, to qualify for 2013. Next slide, please. And these here, I'm not going to go through every one of them, but these are the two measure group sets that are available for PQRS reporting through the Digestive Health Recognition Program. Next slide. Requirements for the 2014 PQRS are essentially the same, but in 2014 you could earn a 0.5% incentive and also avoid a 2% penalty in 2016. And the deadline again for submission of 2014 PQRS through the Digestive Health Recognition Program is March 2015. Next slide. How to get started with the PQRS? We encourage you to visit the Digestive Health Recognition Program's website, which is listed in the slides. Review the policies and procedures, review the data collection form. You will have to register and pay a small fee, which is $300 for AGA members per disease state that you report. There's technical support available via the website, and any other questions can be directed to the email listed in the slides. Next slide, please. The next program I'm going to talk about is the Physician Value-Based Payment Modifier, which is relatively new. Next slide. This is the federal government's way of transitioning from what PQRS was, which was pay for reporting, to a pay based on performance. So no longer can you just report measures. CMS is actually going to look at how you do performance-wise. Another added element for the value-based payment modifier is that CMS will not only measure you on quality, but also on cost. The program is linked essentially to PQRS participation, and there's also a phased rollout. Starting with 2015 payments, that is the first year that payments will be adjusted under this program, but it will be based on 2013 reporting, so reporting from the last calendar year. This 2015 payment adjustment will only affect large group practices of 100 or more eligible professionals. For the 2016 payment adjustment, which is based on 2014 reporting, so this coming year, the modifier will affect small groups of 10 or more eligible professionals. And finally, by 2017, based on 2015 reporting, the modifier will affect all physicians. And this is a statutory requirement for CMS to apply the modifier to all physicians by 2017. I do want to also note before moving on that I use the term eligible professionals here. For purposes of the value modifier, CMS actually defines eligible professionals as not just physicians, but nurse practitioners, PAs, nurse anesthetists, OTs, PTs, and even dietitians. So you will want to keep that in mind when trying to figure out whether your group will be defined as or will qualify for the next payment year, this coming year. Next slide, please. So the deadline to register for the 2015 modifier has actually already passed, but I put this up here just to illustrate CMS's phased implementation of the program and how each year the requirements are getting a little more complex. But in 2015, as I said, the modifier will only apply to groups of 100 or more eligible professionals. The groups of 100 or more eligible professionals have two options. If they do not participate in PQRS and take no action in 2013, they will receive an automatic cut of -1%. And this comes on top of the penalty they would have already gotten for not satisfying PQRS reporting requirements that year. So it will be a total of a 2.5% cut. On the left side of the screen, if a group of 100 or more does participate in the PQRS as a group practice and they take no other action except satisfying PQRS requirements, they will be held harmless, as you can see in the middle, and receive a 0% adjustment. They can volunteer to be held further accountable under a quality tiering election, which is essentially the pay-for-performance element of the value modifier. And if they volunteer to be held accountable for their cost and quality measures, they can receive a positive, negative, or neutral adjustment based on performance. And the maximum payment cut in 2015 is a 1% cut if you are a low-quality, high-cost group. Next slide, please. 2016, the rules are a little different. As I said, the program is expanded to groups of 10 or more eligible professionals. If that group of 10 or more takes no action, does not satisfy PQRS requirements, they are subject to a 2% cut, in addition to the 2% cut they would receive under the PQRS in 2014 for a total of 4%. On the left side again, if they do participate in the PQRS as a group, the change here in 2016 is that quality tiering is no longer voluntary, it's mandatory. However, smaller groups, those with 10 or more eligible professionals, will only be held accountable, can only receive a positive or a neutral adjustment. They can't receive a negative adjustment. Groups of 100 or more can still receive a negative adjustment based on their quality and cost performance, up to a max of now 2%. And I note on the bottom corner here, there's a new 50% rule, and this rule is new for the 2014 reporting year. And essentially, this is pretty important to note, because if a group practice does not register to participate in the PQRS as a group practice, so they fall on this right side of the screen, but at least 50% of the group's eligible professionals still satisfy PQRS reporting requirements as individuals, so you report on your own, such as through the Digestive Health Recognition Program, that group will not receive the automatic cuts under the modifier, and CMS will then instead put them on the left side of the screen and assess them as a group automatically using the quality tiering approach. So you will want to, if you are a group practice that falls under this category, the groups of 10 or more, you will want to consider that as an option for the coming year. Next slide, please. As part of the value modifier and leading up to the development of this program, CMS has been providing physicians with annual reports that provide them with comparative information on the quality and cost of care furnished to Medicare fee-for-service patients. It also provides beneficiary-specific information to help you coordinate and improve the quality and efficiency of care furnished to these patients, and information on how the group would fare under the value modifier. Some of you may have already received these reports. In the fall of 2013, CMS distributed reports based on 2012 data to groups of physicians with 25 or more eligible professionals. In the late summer of 2014, they will be distributing these reports to all groups and solo practitioners, so everybody should receive them. Next slide, please. The next two slides, I'm not going to spend any time on really, but you could print these out and follow them at home. They're instructions for how to access your quality resource use reports. If you do have any questions about this process, you can send an email to me or AGA staff, so you could go on to the next slide, please, or two slides. And so, in reviewing your quality and resource use report, it's very important that you pay careful attention to them because they are an opportunity to preview the methodologies that CMS will use when it does apply the value modifier to either your practice or you as an individual. So you'll want to look to verify the accuracy of the eligible professionals billing under your group's tax identification number during 2012 because that's the way CMS defines a group. You'll want to determine how your group would have fared under the value modifier. There's a performance highlights section which will essentially show you the methodologies that CMS uses for the modifier. You'll want to examine the number of beneficiaries attributed to your group and the basis for their attribution to make sure it's accurate. Evaluate how your group's performance on quality and cost measures compares to other groups. Understand which attributed beneficiaries are driving your group's cost and quality measures, and identify beneficiaries that are in need of greater care coordination. Next slide, please. The next program, actually, before we move on to the next program, here is a quick timeline for the value-based modifier for 2016. In the spring of this year through the fall, you can register as a group practice to participate in the PQRS, which, as I noted, gets you out of the value modifier. By the first quarter of 2015, you would have to submit data, PQRS data, to CMS. But by the third quarter of 2015, you should be receiving a 2014 quality and resource use report. And then by January 1st of 2016 is when the value modifier will apply to group practices with 10 or more eligible professionals. Next slide. So the last program I'm going to talk about is the Electronic Health Record Incentive Program. Next slide. This program was authorized in 2009 under the HITECH Act. It provides Medicare and Medicaid incentives to hospitals and physicians for the meaningful use of certified electronic health record technology to improve patient care. I just want to note that it's not a reimbursement program for replacing or installing a new EHR. You have to actually demonstrate that you're using an EHR that has been certified by the federal government as having certain functionalities that can help you to satisfy specific objectives that the federal government has set, including the reporting of clinical quality measures. And some of these, just as an example, include using the EHR for physician order entry, for e-prescribing, providing patients with clinical summaries at each office visit, and maintaining active medication lists. As of December 2013, over 80% of all eligible professionals have registered to participate in the EHR incentive program, and about 64% have received an incentive payment for meaningful use. And since 2011, CMS has paid more than $17 billion in incentive payments to both physicians and hospitals. Next slide. This chart here, pie chart here, shows the percent of Medicare eligible professionals who have received an EHR incentive payment by specialty from 2011 through 2013. And as you can see, of all the physicians receiving an incentive, 4% were gastroenterologists. 61% of all Medicare eligible professionals who have received an EHR incentive payment are non-primary care providers, which is interesting to note, although it's broken down by multiple specialties, obviously. Next slide. The EHR incentive program takes a phased approach to meaningful use. Meaningful use, as I noted, is demonstrated by meeting specific objectives and quality measures, but over time, CMS will require you to meet higher stages of meaningful use and report on more robust measures. So stage 1 actually goes from 2011 to 2014, and it focuses more on data capturing and sharing and using your EHR to track key conditions. Stage 2, which goes from 2013 to 2016, focuses more on advanced clinical processes and more rigorous health information exchange, also more patient engagement. And stage 3, which now has been postponed till 2017, the rules have not yet been finalized, but it's expected to focus more on improved outcomes, again, patient access to self-management tools, using more innovative locally generated measures, and also requiring 100% compliance with certain measures. Next slide. So the earlier you start this program, the more you are eligible to earn. And incentives have been available since 2011, and they will continue through 2016. The table I provided at the beginning of my presentation shows that if you were a meaningful user starting back in 2011, you were eligible over all these years to earn up to the max of $44,000 over 4 years. 2014 is the very last year physicians can initiate participation in this program and qualify for an incentive. New participants in 2014 can earn up to $24,000, so less than those who started earlier, but still a significant amount of money, if they demonstrate meaningful use from 2014 through 2016. And the incentive payment is higher if you participate under the Medicaid side of the program. However, beginning in 2015, physicians who don't successfully demonstrate meaningful use will be subject to a penalty, and as you can see, it goes from -1% and increases all the way to -5% by 2019. A few quick other things to note about 2014. The 2014 reporting year, it does mark the beginning of a restructured meaningful use for stage 1. So if you've already reported under this program and have reported for stage 1, you'll want to revisit the measure specification sheets that are out this year because the requirements have been modified slightly. 2014 is also the start of stage 2 for physicians who have already completed at least 2 years of stage 1. And finally, all physicians in 2014 have to upgrade to a new edition of certified electronic health record technology. The earlier edition was from 2011. It will no longer be acceptable. So if you have, again, participated in the program, you'll have to figure out if your technology, your EHR, still meets these updated standards. And because of these new requirements, CMS is only requiring a 3-month reporting period in 2014, no matter what stage you're in, so that physicians have time to upgrade to this new technology. Next slide. In terms of reporting for the EHR program to avoid the penalty, which starts in 2015, if 2011 was your first year of demonstrating meaningful use, you'll want to do it for a full year in 2013 to avoid the penalty in 2015. Same with 2012 if that was your first year of demonstrating meaningful use. If you started the program last year in 2013, you only have to demonstrate meaningful use for a 90-day reporting period in 2013 to avoid the penalty in 2015. And finally, if you're just starting this year, you'll want to demonstrate meaningful use for a 90-day reporting period in 2014, but you must finish up that reporting period by October 1st, 2014. Next slide. And the program also does include hardship exemptions. Has the next slide come up yet? Not seeing it on my screen, but hopefully everybody else sees it on theirs. But the program does include a set of hardship exemptions. These include hardships due to lack of infrastructure, such as internet access. If you are a newly practicing physician who would not have had time to become a meaningful user, unforeseen circumstances such as a natural disaster, patient.
Hello?
A certified electronic health record for over 50% of your patient encounters. Next slide. So getting started for the program, you'll want to, and here's a little checklist for getting started since it's a bit complicated. You'll want to first verify that you are eligible for the program. Hospital-based physicians are actually not eligible. And a physician is considered hospital-based if 90% or more of his services are performed in a hospital, inpatient, or emergency room setting. You'll want to register for the program at the website listed on the screen. You can register before having a certified EHR installed. If you register, it doesn't mean you have to participate, and you can cancel your registration at any time. Then you'll want to actually adopt a certified EHR. As I mentioned, it means that the EHR is federally certified, so CMS provides a list on its website of those EHRs that are certified under the program. You'll then want to you'll want to demonstrate meaningful use by meeting the reporting requirements, and then attest to demonstrating meaningful use, which is a legal statement you basically make on CMS's website, demonstrating that you fulfilled the requirements of the program. Next slide. And in terms of important dates for the EHR incentive program, you'll want to attest for the 2013 program by February 28, 2014. Similar to the PQRS program, it's not too late to still satisfy the 2013 program by reporting by February 2014. October 1st, as I mentioned, 2014 is the deadline to adopt and demonstrate meaningful use to avoid the 2015 penalty of 1%. And by December 31st, 2014 is the end of the 2014 reporting period for physicians to qualify for EHR incentives. Next slide. This last slide here just, again, I know I went through a lot of information and it must be making everyone's head spin, but here are some additional resources that will help you navigate each of the programs I spoke about today, the PQRS, the Value Modifier, and the EHR Incentive Program. The AGA's website also does provide very valuable information about each of these programs as well. And with that, I will turn the microphone over.
All right, thank you, Rachel, for that very informative presentation. I think it helped clarify and summarize the regulations that we're currently living under. For my part of the presentation, I wanted to sort of give a real life how it's time to get prepared. You go to the next slide. As Rachel said, there's a storm coming. There's still some physicians who are praying that it's a passing storm, but it's really not. It's more of a permanent climate change. Next slide. You don't want to be stuck like this gentleman, left out with a ever getting smaller piece of ice in which to stand on. Next slide. So for my agenda, I'm going to go through it quickly so we'll have some time for questions and answers at the end. But I want to try to present a general strategy for how we got prepared and how we're preparing for successful implementation, not just for the three measures that we're talking about today, but also for dealing with the ACA in general. Obviously, today we'll be focusing on what our group did to get ready for PQRS, VPM, and meaningful use. But if there's any questions at the end, somebody can ask, or they can email me if they have other specific questions on how we're dealing with many of the other policies for the ACA. Next slide. So just as a little bit of a background, what's going on in Rhode Island. As you may know, Rhode Island is geographically the smallest state in the country. We have under 1 million people living in the state. There's only 3 dominant healthcare systems in the state, which makes it fairly easy and manageable when looking at it from that perspective. And very early on, the federal government noticed this and decided to apply some federal grant money to the Rhode Island area to establish coordinated care systems as well as alternative payment models. We're sort of an alpha site or a petri dish, depending on how you want to look at it. But because of that, we have a very maturing primary care-based ACO and PCMH model. We have a successful healthcare exchange program, which currently is federally funded, but as of next year, it's going to be mandated to be self-funded. And what's very imperative and very important for anybody who's listening is to really understand your market. So we understand what's going on at the federal level and also in our state. Each one of you should learn to figure out what's going on in your region, because a lot of this will be regionally driven. Next slide. So as a way of background, University GI is 19 physician providers. We have 5 nurse practitioners. That makes us the largest GI group in our state. We are spread out geographically with 3 main campuses, but we also have satellite offices throughout the entire state, covering all the population centers of our state. We are affiliated with 4 ambulatory surgical centers. We have had a fully integrated EHR system well before meaningful use was implemented. We first started our EHR in 2008, and we're on our 3rd generation, each time changing it to meet up with the regulations of the federal government. But what this has allowed us to do is very early on start looking at group-specific metrics for quality and start having patient satisfaction surveys, and we've been collecting data all along. Last year, 2 years ago, we began to realize the importance of an independent registry to help us collect some of our data, and we signed on to the AGA registry, which has been very successful, and I'll show that some of that information in a second. But also important for people to know is your insurers are profiling you currently. Rhode Island Blue Cross Blue Shield has provided us with our report cards for our cost and quality. And I guarantee that that's going on nationally for UH, Blue Cross Blue Shield, and the Aetnas across the country. Also, our group has become and has adopted the idea of unit care measures and alternative payment models. Next slide. So as way as a general strategy, the days of having 1 or 2 partners act as managing partners is really going by the way of the dinosaur. It's just way too much information for 1 or 2 people to process. So what we established was a very robust committee structure. And what the committee structures are is physicians will head the committees or will be volunteered to head a committee. And what their job is to research particular and become experts on particular regulations and policies that are undergoing and occurring during the ACA. Their job is then to educate the partnership at our bi-monthly or monthly meetings so that every partner then understands what each individual committee is working on. Those committees are empowered to allocate staff if need be. They can ask for financial resources that's then approved through a finance committee. But in reality, what they need to do is they help drive the partnership's reaction to any kind of policy that's being thrown at us through the ACA. Today we'll be talking about examples of committees that we've used for these particular regulations, and one is the Processing Committee, the Healthcare Reform Committee. We have an IT committee and a Compliance Committee. Next slide. So how did we look at PQRS? As Rachel stated, there was a few ways for which we could attest to PQRS. Claims-based seemed to be the quickest and easiest for us to do in 2013. And what we did, we looked at all the different various reporting policies, and we decided to use the medication reconciliations claim. So what we did in 2013 was every Medicare patient came through one of our offices for the entire year, had their medications reconciled on admission, a check-in, and then also during the office visit by the physician. This was when the physician completed the reconciliation. We then notified our billing department via code in our EHR, who then submitted the information to the CMS. This was fairly cumbersome, but what it has allowed us to do is to avoid the penalties and gave us time to implement other programs. What we realized early on, however, was that using a CMS-approved specialty specific registry would be less cumbersome and also provide us with much more important data. when deciding on which registry to use, we came up with 4 criteria. And I use the 4 criteria theme. We'll be using that often during this process. So the committees established 4 criteria when looking at a registry. The most important one was, does it satisfy the requirements of PQRS reporting? There's a lot of registries and a lot of data out there that can help you collect your data, but we wanted to make sure that we weren't duplicating our efforts. The next most important thing was, is it compatible with our EHR? How much money would it cost to update our EHR to get the recognition or the registry that we need to use? Next, we look at the cost effectiveness, not just how much is the initial upfront cost, but how much does it cost to train the staff and to implement and to process the data. And lastly, which I find most important for my committee, is that is the registry not only able to give the information to CMS, but can it provide us with some data capability so that we can look at this. Early on, we were using the AGA registry in our own group metrics, and we started collecting data as early as 2012. Next slide. Going forward, we are going to implement the AGA Health Recognition Program, and we will be using the group measures of HCV and IBD. This is very nice, as the information will flow directly from our EHR to the AGA, and the AGA can then report it directly to CMS. It's a much smoother and less cumbersome model. The Digestive Health Recognition Program also will provide UGI with the information that I personally like. It gives each doctor his own individual data, it gives us group data, and it also gives us national trends. We then empowered the processing committee to meet with the individual doctors on a quarterly basis to help them modify their behavioral patterns if they tend to fall outside the group metrics or the national metrics. Next slide. So what have we done successfully? Well, we have, as I said, successfully attested to CMS, and we have proof that we've met PQRS standards, at least for 2013, by using the CMS claims-based process. But this has allowed us to avoid any penalties for 2015 payments and kept us out of the penalty box. Also, what we've successfully done is, for the last 2 years, we've collected data through the AGA registry, and I've used that data to help negotiate with private payers, self-insured, and also to help strengthen our relationships with the primary care-based ACOs that have developed in our area. Going forward, we're going to continue to use the new registry from the AGA to collect data and to maintain our quality and help us prove that our behaviors are producing the quality that we need to get recognized. Next slide. With the value-based modifier, as Rachel had said, the ACA has mandated CMS to pay for performance and no longer just pay for your services. So what CMS is doing is they are profiling us, and the QRUR, which is like a report card for your quality, is a sense of, in a sense, is a type of profiling report. It allows physicians to get feedback on how they're doing. What we're going to be doing, since our group is under the 100 mark, we're going to be looking at our data our reports starting in 2014. However, what we've done is we've assigned myself and one of the other physicians who's in charge of the processing committee the role of truly understanding the reports and how those reports can then help us determine and improve our behaviors. And what we'll be doing is we're going to try to help improve physician adherence to the measures, as well as showing that our patient outcomes and experiences have improved. Next slide. With meaningful use, again, we applied the same process that we applied when we went with PQRS. We, again, have a similar structure with the committees. In this sense, we've used the IT committee, the billing committee, and the compliance committees. We identified staff with strength and expertise in these certain areas, and we've been blessed with a very skilled practice manager, as well as a very skilled billing supervisor. And they've come up with practices along with physician oversight and leadership. The initial goals were to confirm that our EHR was CMS certified, As Rachel pointed out, that's very important. We'd already had an EHR. We also wanted to make sure that any kind of meaningful use data or process that we put in did not interfere with our practices or patients' flow, therefore not to decrease the workload of the physician. Most important was to, anytime you're collecting data, to be certain that you don't breach HIPAA and that all HIPAA policies are followed closely. And then we wanted to make sure that we collected data that would be useful to us as well as useful to the federal government. Next slide. In stage 1, you have 15 core CMS core measures and another 10 or 5 menu measures that you have to choose from. We again applied 4 criteria when looking at which measures we wanted to use. Most importantly, we wanted to make sure that whatever measures would parallel our physicians' practice patterns. We also wanted to do any measures that were duplicated by our state, because a lot of your states will also have their own meaningful use requirements. So instead of increasing the amount of measuring that we needed to do, we wanted to have measures that would be useful for both the state and the federal government. We wanted to make sure that any criteria that we used was compatible with our EHR. And we were hoping that any kind of data that we collected also had some specialty-specific appropriateness for us. Next slide. We found that many of the requirements for capturing data during the meaningful use stage 1 could be done by just modifying our intake form. A lot of time was spent modifying this intake form and then training the MAs and the RNs in our practice on how to input this data with the strictest HIPAA policies in mind. And then all the data was implemented by the staff at the time of the visit. But the important thing is that each physician at the time of the visit in the exam room needed to review and revise all information. You'd be surprised how quickly the information can change from the waiting room to the exam room. But it's required that each physician review it and revise all information with each patient. Next. What we've done successfully is we have successfully attested and received all stage 1 incentives. We received it for individual. In order to receive it for individual physicians, it had to be applied for with our individual NPI numbers, and each NPI number, each individual physician, in order to get the maximum incentive received, had to attest or approve meaningful use. Also importantly, our EHR was able to generate reports directly to us so that we could meet first. It was met every 2 weeks with physicians for compliance, and then the compliance committee started meeting monthly with physicians, and any action taken or any report that's reported with physicians is documented in your EHR. And believe it or not, this is a very important quality to note, because CMS will come back and audit your records later on, and they're going to want to see that, and it'd be easy. You want to be able to have it held in your EHR. And lastly, we found that the information that we were collecting through our meaningful use actually had value in promoting our relationships with the primary care-based ACOs, PCMHs, and even the insurers in our state. Next step. Next slide, sorry. So as Rachel pointed out, stage 2 is ongoing right now. It's a different focus. We're focusing on advanced clinical processes. We're restarting the exact process that we did before. We have the same committees involved. We're establishing, again, the same criteria then of which to apply for which measures and which measures we'll be using going forward. There is added measures from stage 2, and we're in the midst of successfully doing that right now. Stage 3 is around the corner, and then this is not going to stop probably at stage 3. I'm sure it's going to ongo. It's going to be ongoing in the rest of our career, at least for some time period. But the goal is that once you get the process down, it's hoped that it becomes easier and easier to implement. Next. Next slide. So as Winston Churchill said, a pessimist sees difficulty in every opportunity, but an optimist sees opportunity in every difficulty. So what I want to say to conclude is that these regulations are here to stay. It is a climate change. So the best approach is to look at the regulations and see how you can use the information that they're requiring us to to provide them and see if there's a way of using some of that information to help benefit the way you practice medicine and improving the way you have quality and also cost. The other way to help this is to get involved at the early stages. We still can influence regulations, and the AGA, through Ms. Groman's consulting group, has allowed us to help maybe influence some of the regulations that are coming down the pike. So if you want to get involved, it's very important to support the AGA's PAC and look in your local locales and see if there's any way locally you can also help influence things. And at that, I'd like to, before we move on to questions, I want to let people know that the AGA has developed an interactive timeline for this presentation. We have one-page documents on each of the topics that will be posted on the website, which is gastro.org. And we will be sending all the participants a link to these documents, as well as posting the webinar quiz and recording this webinar later this week. So now let's, we still have time for a few questions. As a reminder, if you have questions and they don't seem to, we're going to take them in turn. If they don't come on, we're going to be posting a Q&A online also. So can we turn on to the question?
Thank you so much, Peter and Rachel. The first question, we've gotten a few questions about if these slides will be made available to the participants, and the answer is yes, we will be including that in the email that Peter just discussed. I'll move on to the first question at this point. The first question is, if you have Medicare patients but you cannot meet the 11 patients as Medicare Part B patients for the measure groups, what do you advise? And I'll direct that question to Rachel.
If they do not have at least 11, I think CMS, and I could follow up in an email about this, but if you do not have at least 11, I think CMS requires you to report the maximum amount that you do have that's relevant to that patient population that needs to be reported under that measure. If they simply don't exist, then I am almost positive that you could fill the rest of the reporting requirement up with non-Medicare patients. But I can verify that, and we could post that on the Q&A that's posted online, just to be sure.
Okay, great. Thank you so much, Rachel. The next question also directed to you. If a group has fewer than 10 providers, are they required to report the value-based payment modifier?
No. For 2014, affecting the 2016 payments, if you have fewer than 10, all you'll want to do this next year is participate in the PQRS to avoid the penalty and earn the incentive. You will not be subject to anything related to the value modifier. That being said, you will want to keep an eye on things, look at your resource use reports that you'll be receiving regardless of whether you're participating in the value modifier, because you will be subject to the modifier next year, which will affect your 2017 payments. CMS has not yet come out with the rules of how they're going to apply it to individual physicians. It will likely be similar to the way it's being applied now, where it will be linked to PQRS reporting, which is why it's very important to get involved with PQRS now. But no, as long as the simple answer is if you have less than 10 eligible professionals for the coming year, you will not be subject to the value modifier.
But just to stress that, it's actually just in the short term, because as you're saying, in the long term, the goal of CMS is that it will, by 2015 for 2017, all physicians will be subjected to it likely.
Correct, yeah.
Okay.
Thank you. I'm going to direct the next question to Kate Detweiler, who's sitting here in the staff office right now, and she actually oversees AGA's Digestive Health Recognition Program. So any of your questions about that specific program, I'm going to direct to Kate today. So the question for Kate is, if we use the AGA Digestive Health Recognition Program for IBD or HCV, do we submit by group or by individual physicians, in particular if we have fewer than 10 doctors?
You do submit by individual physicians.
Can you just repeat that?
Sure. You do submit by individual physicians using Digestive Health Recognition Program.
Great. Thank you so much, Kate. One more question for you, Kate, while we have you here. That came in. For the Digestive Health Recognition Program, can you upload your patient data, or do you need to enter your patient data individually per patient?
It can be entered manually, but there's also a data upload possibility. There's essentially a data template that can be used. So if you can extract your data from your electronic health records into an Excel or a comma delimited file, it can be uploaded directly to the system.
Great. Thank you, Kate. Another question that just came in that Rachel or Peter could probably address. Can you comment on some of the information provided in the quality and resource use reports?
Would you want to start with that,
Peter,
Rachel?
have you? Yeah.
I'm versed in it because I've been working on it with the. I was one of the two GI doctors who were, involved with CMS through the Alliance. I have not been able to yet pull up our own or my QRUR because we're a group of less than 25. But I do understand it. The data up until recently seemed like it was mostly going to be profiling things that were not necessarily specially specific, and I'm hoping that has changed since they've expanded the PQRS reporting information. I don't know if you could speak to that in more detail.
Yeah, to date there has been concern that the measures reported on there are not necessarily applicable or attributable to specialty physicians, and that's actually a larger problem with the value-based modifier. Essentially what CMS will include on there to date, they usually typically calculate any PQRS measures that may apply that you either reported or that they automatically calculate. In terms of quality, they also will report on some outcome measures that they automatically calculate. One is an acute prevention composite that looks at like bacterial pneumonia, UTI, and dehydration. The other is a chronic prevention composite that looks at like heart failure and diabetes. There's also an all-cause readmissions measure. So again, a lot of these are not necessarily directly relevant to you or your practice. On the cost side, they typically calculate a total per capita cost for all beneficiaries measure, and that measure is actually going to be used for the value modifier. They also calculate a total per capita cost for select patients with select conditions such as diabetes or heart failure. The annoying, frustrating thing about these total per capita cost measures, they'll attribute a beneficiary to you if your group provides the plurality of primary care services to that patient. Once you're linked to that patient, you in these reports and later on for the value modifier will be held accountable for all of that patient's Part A and Part B costs. So again, even though you provided the plurality of primary care services, that's not necessarily, you're not necessarily in control of everything that contributes to that patient's Part A and Part B costs. And this is where the AGA and their policy staff, along with my company, Hart Health Strategies, has been trying to essentially lobby and meet with CMS repeatedly to get these measures changed because they are problematic. CMS is working very hard to develop more specific, specialty-specific episodes on which to base these cost measures. They're contracting out with different universities and other researchers and working with specialty societies to develop more specialty-specific episode-based groupers, but they are not yet there yet, and they have this statutory mandate to start this value modifier and measure cost. So they claim this is the best way to do it in the short term, which, again, is frustrating and why we've pushed a million times for them to slow down the program altogether. But they are hopefully moving in the right direction.
Thank you. The next question I'm going to direct towards Kate again. Again, she oversees our Digestive Health Recognition Program here. If we have been reporting PQRS using a claims-based reporting option, can we still use the AGA Digestive Health Recognition Program?
Absolutely. The deadline for the digestive health the PQRS deadline for the digestive health recognition program is later than the claims reporting, so that is one advantage. Also, with the digestive health recognition program, you also get access to a performance improvement module to achieve maintenance of certification, and also the Bridges to Excellence program. So there are advantages to using digestive health recognition programs, and it can certainly be done in conjunction with claims-based reporting.
One of the other advantages that we found was that the AGA will be providing your data directly to CMS, but it also has the capability to then give you back some data for feedback so that you can then use that data to prove your quality, not just for the federal government, but more importantly, for your relationships in your local community with your ACOs or any alternative payment models or integrated systems that you're going to be a member of.
Thanks. I have a question about meaningful use. Probably either Peter or Rachel may be able to answer this. We too have successfully attested for stage 1, and we are also moving on to stage 2. We were told to pick a specific time to perform attestation. If we choose the 4th quarter, we would not be able to attest until after October 1st and will be penalized if she understands the slide correctly. I was under the impression that we would be able to attest after December 2014. So I think there's some confusion about when that person can attest, if it can be after December 2014.
I'll have to defer that to Rachel. I don't know that. We are actively trying to, complete stage 2 now. So I don't know what the final deadline would be. I hadn't heard that we had to do just 1 quarter, so I could definitely check on that. I don't know if, Rachel, you know that off the top of your head?
Yeah, that like I said in my presentation, because the CMS or ONC is switching to this new edition of certified EHR criteria, it's just a 3-month reporting period, but for technical administrative reasons, I believe the deadline I know is October 1st. Whether that applies to eligible professionals that are new to the program and not those who have been already participating, I would have to check on. I believe it applies to everyone, but I could clarify this with CMS, and we could post that in the Q&As as well.
Okay, that'd be great. Thanks.
Perfect. Thank you so much. Well, that's all the questions we have time for today. As we mentioned, we'll be posting the other questions that people had and the answers to those, and we'll be sending those out to all participants. Just want to thank everybody again for joining us today for our webinar. The recording of this session will be available on the AGA website later this week. And we ask that you continue to read AGA eDigest for more information on these and other federal programs that will affect your practice of medicine and how AGA is helping you to prepare. So thank you very much, and we appreciate your time.
Thank you.
Thank you.